as well. So if I run into trouble with the tube, I will convert to the thyroid cartilage method. Normally I will get to 1000 or 2000 amplitude. So maybe it's good to learn both methods rather than relying only on the EMG tube. That's all.
Thank you, Raiza. I believe there's another question, but we are running behind time. So if it's possible, I think I would like to ask Prof. Marina to answer the question in the Q&A box. So we shall move on to the next session, which is the case discussion. Yeah? So I don't have much time for this case discussion, so we'll run through quite quickly. So thank you to all the panelists, Professor Dr. Marina Makbaki, Professor Dr. Irfan, Prof. Haiza and Dr. Liu for being part with us to share this case. I would like to acknowledge Professor Dr. Marina who is managing this case. Okay, so we have here a middle-aged lady who was diagnosed with multinodular goiter and hypothyroidism for the past 10 years, and she was actually treated in another center on carbimazole and also has a history of hypertension. She presented with a 1-year history of anterior neck swelling, which was associated with 6 months history of hoarseness and voice fatigue. For the past 3 months, she has a new complaint in which she complains of dyspnea and noisy breathing, which has progressively gotten worse to develop noisy breathing as well as reduced effort tolerance, which is very significant. She would get tired and dyspneic after walking about 50 meters. So that's a very short duration or short area when she walks. Okay, so we move on. So on examination, she has a soft biphasic stridor. The hoarseness is not severe. Overall, dysphonia grade 1. Her maximum phonatory time is 11 seconds. Respiratory rate of 18 breaths per minute. BP is slightly on the higher side, especially the diastolic range. Heart rate was 93 beats per minute, and SpO2 was 99% under room air. So intraoral examination showed no medialization of the electropharyngeal wall. So I'm going to show the scope findings of this patient. So this is a video endoscope of the patient. For the benefit of the attendees, since we have a mixed cohort, both the general surgeons and the ENT surgeons, this is the left vocal fold and this is the right vocal fold. And you can see that on a closer view, the patient has a vocal nodule. There's something that you don't need to worry that much for this time being. You can see the left vocal fold is slightly at a higher level compared to the right vocal fold, and the movement of the left vocal fold is paretic. That means there is reduced movement both to abduction and adduction, but there is still some mobility. So in the ENT clinic, if you can see now, we have put in a nozzle, the blue colored nozzle. We've administered local anesthesia so that we are able to put down the scope at the level of the larynx, and it doesn't cause the patient to cough or gag. So on closer view, you can even appreciate better that the left vocal fold is reduced in mobility. And lo and behold, you can see the abnormal vascular pattern at the level of the subglottis, and here you can see an intratracheal mass here, which is seen arising from the left wall of the trachea. So for the ENT postgraduates, you can see that this shape that I'm showing here, this is a subglottic wedge. So you know that the mass here is coming below the subglottic wedge, which is arising from the trachea. And you can also see that the airway is quite compromised at this point, giving rise to the stridor. So before we go to this slide, perhaps if I can ask Professor Dr. Irfan. Prof. Irfan, are you there, Prof? Prof. Irfan?
Yes, sorry,
yeah.
I'm typing for the answer actually for the question. All right. So,
Prof, did you have a gauge of the case?
Can you just summarize the question? Only the question.
So only the question. I haven't gotten to the question, but did you have a gauge of the case?
Actually, I'm quite lost track. I'm focusing to answer the question just now.
Never mind, never mind. Prof. Raisa,
Maybe Prof. Raisa can help first. Sorry.
Okay, Prof. Raisa, maybe for the benefit of the postgraduate students and the young surgeons, if we have this scenario, a middle-aged lady, 40 years old plus, previously was treated for multinodular goiter, and then now presenting with 1 year history of rapidly enlarging anterior neck swelling associated with airway symptoms as well as voice problem. When we are able to see vocal fold paresis on the left hand side, what would be the main diagnosis that you would entertain at this point?
So this patient here has a long-standing goiter, and it is interesting because it is a toxic goiter rather than because the patient was on carbimazole.
Yes.
So two things that you, as what Dr. Imi mentioned, get to the common one will be the follicular and papillary. But here we are not talking about endemic goiter. So endemic goiter, iodine deficient tend to be follicular, iodine sufficient, iodine rich, hyperthyroidism tend to go more towards papillary. So top on the list, I think you have to think about papillary. But I think the patient is quite elderly as well, middle age.
46, Prof. Middle age.
No, younger than me, so still young. Less likely to be anaplastic throat cancer. So I think in this case you have to think about the common well-differentiated throat cancer, which will be the papillary, and FNAC will be adequate for you to get the diagnosis.
Okay, thank you, Raisa. So basically, we made the provisional diagnosis of a well-differentiated throat cancer with intratracheal extension and left unilateral vocal fold paresis. So I would like to move on to the next question. So now we have a lady who has soft stridor, although it's a soft stridor and the oxygenation is well maintained, but the airway is compromised. So how do we go about investigating this lady? Bear in mind we don't have a histological diagnosis at this point. So Prof. Irfan, what are the investigations that you would consider at this juncture?
Thank you, Mawada. I think for all the complex thyroid, whether it is benign but the size is big, or if the malignancy is suspected, CT scan is a must as soon as possible, not only to assess the what is the remaining lumen left, especially if the invasion is suspected. Also, we want to see whether the mass actually causing invasion or suggestive of involvement of other adjacent structure that may also not only explaining the symptom and sign, but also may affect the plan of surgery, the type of tube that we want to do, the discussion with the anesthetist. I think the standard answer for every investigation in a thyroid mass, whether it's a complex benign or if malignant, a CT scan, other than the preoperative rhinoscopy as usual. But of course, we need to secure if the patient really is okay, there is normal assessment as usual. But I think CT scan is needed to do.
Thank you, Irfan, for a very comprehensive answer on the radiological investigation. What about histological investigation? We know that this patient is compromised in terms of the airway. So what do you think is the best investigation to obtain?
Yeah, I think FNAC should be the first line of everything. However, maybe if FNAC seems to give no what I want to say is no difference between type of surgery, I think that can be bypassed, because sometimes we just need to confirm whether this is anaplastic or not. If all the existing evidence say that it's not anaplastic, whatever it is, if patient is surgical candidate, whether it is a MNG or PTC, I think that the FNAC only gives some maybe additional clue if it has. Otherwise, as long as you can exclude anaplastic, I think surgery is a way to go, even with a lung metastasis for differentiated thyroid CA, like lung mass of PTC, as Riza also mentioned just now. He also did thyroidectomy in whatever M stage of the differentiated thyroid CA, because we know as we remove the main bulk of the tumor, the rest will be taken care by the RAI. That's my opinion.
Brilliant, Prof. Irfan. So not necessarily that you would wait for a conclusive diagnosis from the FNAC. Suffice to say that it's not anaplastic, then you would proceed in a surgically indicated patient. Yeah. So, Prof. Raizat, would you like to add on to the answer, Prof?
Okay, thanks, Mawada. In our setting, we tend to do ultrasound first, because we perform our ultrasound by ourselves, and then we perform the ultrasound FNA also by ourselves. So it can be easily done, and then if the patient is still okay, as what Irfan said just now, the life is not compromised. If you have to go for surgery, then no choice. But if you can wait for the FNA, which you can get it within 2 days, 3 days. So if the patient can wait for that, and that's going to change your decision, especially in terms of doing the neck dissection and the aggressive surgery. You know it's anaplastic, again, maybe it's going to be palliative in this case, then you don't need to be very aggressive. But if you know something that is curable or potentially curable, you tend to be more aggressive. In terms of CT scan, I agree what Prof. Irfan said just now. If there is evidence of invasion, you must go for the radioiodine. Even people say that, for the CT scan. Even people say that you shouldn't do CT scan for pulmonary thyroid cancer. I think that should be reserved, in the sense that in the case of invasion or affecting your surgical planning, you must do. But in small papillary thyroid cancer or follicular thyroid cancer, when you can easily do the surgery, and then the best not to do CT scan, because that will delay the radioiodine. So you have to look at the case-by-case basis rather than generalize everything.
Okay, Prof. Raizat.
Mau, I nak tanya soalan satu kepada Prof. Irfan dengan Prof. Raizat. Would they consider doing frozen section intra-op just to know whether this is anaplastic, or would it help?
Okay, frozen section is difficult actually to differentiate between the different type of thyroid cancer. We tend to do frozen section if we think it is lymphoma, because the treatment for that kind of thyroid disease is not surgery, it should be chemotherapy. So you just need to get the correct biopsy. But even if it's anaplastic with airway compromise, you still have to do something, at least to debug. And we don't routinely do frozen section. You can't differentiate between follicular or papillary from frozen section. You may be able to get some idea, but I'm not sure about
Same Prof. Raizat. Actually, I never do frozen section for derivation. However, if there is a contradicting evidence, for example, from radiology, say it's a benign or not benign, a differentiated thyroid CA, but from our palpation is cemented heart, is anaplastic anti-proven, otherwise we may take a chance to do a frozen section. Otherwise, it's not, like Prof mentioned, it's not a routine and less value. It's mainly just to not differentiate between follicular or papillary. It's just to, like I mentioned, is this anaplastic or not? Because it does matter very much when we need to go home at 12 midnight, or we can safely go at home at 5 p.m.
Thank you. So basically, we have heard about fine needle aspiration cytology, and there are two ways of performing this. The surgeon performs it under the ultrasound guidance, or is performed blindly just based on clinical palpation. So in most of the complicated cases, we see huge thyroid tumors, and sometimes it's difficult to target where to take this fine needle aspiration cytology from. So maybe I would like to ask any of the panelists in terms of their experiences, how do you gauge where to get the samples from? Because it's very important when you deal with the huge tumor, you want to get representative samples.
Saya jawablah, Atif Raizat jawab skema jawapan. Saya jawab soalan jawapan biasa-biasa dulu ya. From our experience, because this FNA is performed by a pathologist or by the radiologist usually in our setting. So it depends on the what is the suspicion and also the clinical appearance. If the diagnosis is gross, and also the imaging finding showed a homogeneous lesion, so a blind, not so called a blind. Without radiology guided FNA is enough because that can be done faster and without less hurdles. However, if the imaging only suggestive like on one pole or one nodule in very specific pole, so that will require FNA for a specific and targeted lesion, otherwise it becomes inconclusive. So perhaps Prof. Raizat, may you present your answers team?
Thank you for Irfan. It depends. It depends. Because if you have a single nodule, then freehand FNA is fine because that's the only nodule. I think the issue when you're dealing with multiple nodules, which nodule that you are going to the FNA. So in that case, then you need to get the ultrasound to see which is the suspicious nodule. It may not be the biggest nodule, might be the smaller nodule. Actually, it is the malignant. So in that case, the ultrasound guided FNA is important. Number two, if you are dealing with complex cysts, when you have the cystic and solid component, you want to make sure that you are getting to the right area to get the epithelial cells. So you need to do the ultrasound guided FNA. But it depends. I think in the center where you don't have those facilities, then you have to make do with whatever you have. In case of complex cysts, normally the best is to aspirate out as much fluid as possible and leave the solid component behind, and then you do the FNA of the solid. But if you have the ultrasound guided FNA, you don't aspirate first, you get to the solid component with the ultrasound guided. And studies have shown, actually, there are so many studies showing that ultrasound guided FNA is the best compared to the freehand. And in cases when you have a large nodule, sometimes the FNA may not be useful at all because the patient will need to go for surgery anyway. Yeah? So I think these are the things that you have to take into consideration.
Yeah, thank you, Prof. Reza. It's very practical tips given there. I'm sure the attendees will benefit from that. I have one last question. So, in this case, the patient has a left vocal fold paralysis, and I would like to ask Prof. Marina, do you think that in this patient, she would benefit from a pre-operative laryngeal EMG or risk stratification or even prognostication?
Thank you, Pramawada, for the question. So, number one, looking at the tumor, I don't think laryngeal EMG is possible because we are dealing with huge thyroid mass that the bulk of mass is at the anterior part of the larynx where normally our needle have to go through. That's number one. Number two, knowing that if it is if it is feasible, let's say the tumor is maybe at the side and we still can put the needle in, that would be great if we can do, but it is more of academic purposes because whatever decision that we're going to make would rely on the intraoperative monitoring if the surgeon is intraop monitoring. That's my answer.
Thank you, Prof. Marina. We have a question here from the attendee. It's regarding thyroglobulin assay from the aspirated sample from fine needle aspiration cytology. Prof. Reza, do you have any experience or what's your take on this?
We don't routinely do to measure the thyroglobulin from the FNA or the aspirate. Actually, because you have to remember, the thyroglobulin is produced not only by the cancer cells, it's also produced by the normal thyroid cells. So, getting the thyroglobulin from the aspirate, if you want to differentiate whether this is thyroid tissue or thyroid cancer from other structures, let's say you are dealing with probably parathyroid. In that case, you probably will not be able to get the thyroglobulin. So we don't routinely measure the thyroglobulin in the aspirate. I'm not sure about Prof.
Agree, Prof. I never have experience with that.
Okay, thank you. So we'll move on. Like to show the contrast enhanced CT of the patient. You can see a huge thyroid mass there, displacing the trachea to the right side, and you can also see that there is a nice split with the great vessels, and you don't see it at the esophageal side. And here you can see that part of the intraluminal tumor coming in from the left side in this patient, and there is also retrosternal extension of the thyroid mass seen in this patient. So, given the scenario that we have at hand, I would like to ask the panelists what is the proposed surgical plan, given that the fine needle aspiration cytology is not an anaplastic carcinoma. So, Prof. Irfan, would you like to start?
In my opinion, this patient will benefit total thyroidectomy with the about the intra-luminal tracheal extension. If the mass can be excised, or we can leave that if it is minimum to the RAI to take over.
Okay, Prof. Marina, do you have any opinion to add?
Dia nak masuk.
I would agree with Prof. Irfan. It looks like the total thyroidectomy is feasible, which I don't do it. Prof. Rahizat would do it. But for the laryngotracheal invasion, in my opinion, I would plan for total resection, and I would gauge based on because it is already stage 4. We can see the intraluminal mass. Stage 4 based on Shin classification for tracheal invasion, and I would gauge based on the CT scan and my endoscopic findings whether how much I need to resect and what kind of surgical approach that I would choose to treat or to resect the airway.
Brilliant. So, Prof. Marina, in addition, this patient has left vocal fold paresis, even though the overall dysphonia is not very bad. It's grade 1, but it is evident on the scope reading. Would you take a consent for any interventions to the larynx or recurrent angina?
Thank you for pointing that out, Prof. Mawadah. Yes, of course. We would also take a consent of KIV, non-selective laryngeal re-innervation and injection laryngoplasty at the same sitting. Because when there is paresis of the vocal fold, there is high chance that the tumor encase the nerve, and there is chance that you may have to sacrifice the nerve. So then when we have the consent, we can do it at the same sitting, the re-innervation and injection.
Thank you. So, according to what Prof has presented earlier on, this patient has a through and through lesion. That means a thyroid tumor that is involved through and through to the tracheal airway with intraluminal extension. And Prof Marina has presented earlier on, whereby a series of cases that we have in UKM, we do a resection, and post-operatively the patient will pick up with the tracheostomy tube. So I would like to ask for experience from USM, from Irfan. Would you like to tell us how do you manage such cases in USM? Perhaps you can do without a tracheostomy after resection anastomosis.
Personally, I don't have experience with the resection and anastomosis of any differentiated CA including the tracheal lumen. So maybe I cannot comment on that. Maybe I should need to provide that and Marina, because they are in a good tag team. One severe thyroid and one severe laryngologist. Personally, I don't have experience doing resection of trachea and anastomosis in embedded PTC.
But probably I want to ask Prof. Irfan, those cases where you debulk, there is stage 4, you debulk intraluminal tumor and tracheostomy, and after that RAI. What is the success rate, in controlling the locoregional disease of the tumor?
Cannot tell also the success rate because I never done that. We have only because in our center, such cases were divided. Last year we go to general surgeon and minimum coming to us. And I assume they will have more experience in managing that. However, I also received not so many reference of managing this tracheal invasion from even a general surgeon. maybe because of the pool and variety of patient, not so much as what you have in your center, Prof. Marina.
Thank you, Prof. Irfan.
May I say something about this case? Bincang bos saya cakap. Okay, I mean, this case I'm a little bit concerned actually if you look at the CT scan. Actually, there's a lot of retrotracheal extension, and it is the left side the tumor. So your esophagus should be somewhere there around that region. So I think in the case, yeah, we need to divide the intraluminal component. But in terms of tracheal resection, I think it depends very much on whether we can completely remove the tumor. In the case that when we cannot completely remove the tumor, let's say it is attached to the esophagus, then I don't think I'll be aggressive enough to do the tracheal resection. So only in the case we just give small amount of tissue, then I would tend to be aggressive in terms of resecting the trachea. I mean, that's my opinion.
It's well said, Professor. Only if we are sure that we can remove the macroscopic disease well to achieve that thyroid tumor, then we would consider doing this invasive big surgery of resection and anastomosis.
Prof. Rahaiza, would you consider doing esophagectomy? Esophagectomy, let's say just small part of the esophagus is involved?
Terkoyak once. No, actually, I'm not the expert in doing it. Actually, there are people doing not the complete resection of the esophagus, because they say that actually the tumor does not invade the whole of the esophagus thickness. Normally, the mucosa are preserved. So if you can dissect the tumor or resect the tumor or part of the esophagus, leaving the mucosa intact, you can do that. But I'm not trained to do that, so I don't think I will do that.
I think one point that you should remember, if it is well-differentiated thyroid CA, we should really give some opportunity for RAI to take over when we are confronting with the patient quality of life. Yeah, similarly also we have M1 like multiple small lung mets. We don't go and resect all the lobe. Yeah, right. Alright, we just remove as much as possible to make sure the dose of the RAI is minimalized, and the remaining small microscopic thing will be taken care by the RAI. Even I've attended one nuclear medicine conference. They claim that RAI can do wonder more than what we think lah. So we afraid that one day maybe all thyroid patients will go to nuclear rather than go to Florida.
Okay, I think that's very good, very important thing to highlight, in the sense that differentiated thyroid cancer, the behavior is not like other head and neck cancers. You have other bullets waiting. So they are, and it's not as aggressive as other head and neck cancers. So you can always have a very good quality of life with the radioiodine and so on. So you have to balance between the quality of life and getting clearance of all the things. Even nowadays, even post-operative detectable thyroglobulin, you still can monitor. It's not that you have to go back in and do and remove everything. So I think there's a lot of discussion that needs to be done.
Thank you, Professor. I think we have covered a lot of controversies just now regarding management of malignant thyroid tumors in general. So we'll move on further to the next step. So we are ready with our surgical plan, and now we are seeing the anesthetist to discuss regarding the perioperative airway management. So Dr. Liu, in this patient, we cannot even palpate the trachea. There's a huge goiter. It has got a lot of component retrosternally, and this lady seems to be on an overweight side. So, Dr. Liu, what are the main factors that would help in determining the perioperative airway management in this case, and how we would decide on the best airway management?
Looking at the CT scan just now, there was not much of a narrowing to the trachea, apart from the intraluminal tumor. And I think assessing the patient with the normal airway assessment and provided that the neck is mobile, there's no other signs of difficult intubation, I think a well-planned direct laryngoscope intubation is sufficient. But of course, with the tumor there, you might need to plan for a smaller tube, and it looks like it's rising from the left side. So while you are, the intubation should not be difficult. The part of when you are inserting the ETT is the one that you have to be careful. Take time to slowly slide the smaller ETT in, and if you can, you would always want to face the bevel. Face the bevel away from the tumor side, meaning you have the you don't want to share the tumor while you're with your ETT when you are sliding the ETT in. And of course, once you are in and you are sure that you bypass the tumor, this is the one that you probably want to just inflate the ETT and make sure that you secure it without moving the ETT more to prevent any bleeding or anything.
Thank you, Dr. Liu. Dr. Liu, may I ask your opinion, because we have a lot of trainees from UKM, both from ENT as well as surgery, and they are telling us that when they graduate from UKM, when they wanted to do these procedures in their hospital, in the Ministry of Health, they are being prohibited, saying that the anaesthetists could not provide services like jet ventilation or fiber optic intubation. So, can you give us some take on that? How can we persuade those anaesthetists to basically start doing this?
Well, I think those from our the anaesthetists from UKM or those who graduated from UKM would have been very familiar with airway management, jet ventilation. The thing that they would need probably is a very good knowledge and cooperation with the surgeon. But once you know what the surgeons want to do, and then with a proper equipment, it should be a very easily done operation and procedure. So in a sense, I think they probably, the anesthetists and the surgeons would have to, like the ENT surgeons would have to group up, discuss and have good cooperation before we embark on all this airway management surgery.
Yeah, so I think it's very that we have good cooperation with all the teams involved, then only we can achieve a good outcome, for the patient. So, having said just now, based on what Dr. Liu has explained, there may be a need to intubate the patient using a smaller tube because it's a compromised airway. You may want to intubate the patient with the microlaryngeal tube, and therefore we might not be able to put in the NIM tube the first time that we are intubating the patient. So I would like to ask Prof. Rohaiza, in this circumstance, what are other methods, can you describe other methods to basically provide continuous intraoperative nerve monitoring?
Thanks, Mawada. I think I did mention in one of my slides here that the standard method is to use the NIM tube, but there are cases that when you have a problem with the airway, you might want to go for the smaller tube or the patient is on tracheostomy. So in that case, I will change my technique to the thyroid cartilage method, which is introduced by Professor Chang. Actually, it's not that difficult. Actually, once you start doing it, it's quite simple because you just need to put the needle at the thyroid lamina. And most of the time we have no problem in performing the nerve monitoring. So we do, for me, I will do all cases, I will use the continuous nerve monitoring because I can move around from the standard method to this thyroid cartilage method.
Jadi lagi kawan dengan semua orang.
Okay, thank you for Raiza.
Jadi
So
kawan dengan
this
Mami.
patient, indeed we proceeded with what
Kita
Prof
pun kawan
has
ni
mentioned,
Daddy dan Mami.
using the Taiwan method to basically get the
Ambil pun
continuous
nak
intraocular
sikat rambut
monitoring.
dia.
And true enough, on the left hand side, the B1 is actually reduced at about 360, and we started with the good B1 on the right side, and the integrity of the nerve was maintained to be normal on the right hand side. However, during dissection on the left hand side, there was a transection, and basically we do not manage to get a signal on the left hand side. So the next question goes to Prof. Marina. So Prof, in this case, what would be the best management of the recurrent nerve in this scenario?
Kalau robot tu dia boleh buat apa dah?
So in this scenario, there is high
Kalau robot
chance
yang
that
tukar
the
jadi kereta,
nerve
dia
has been
panggil apa?
transected, or maybe I would discuss with the endocrine surgeon. Did the
Robot tu
endocrine
dia
surgeon
tukar.
manage to
Tukar
identify the nerve or not,
Jadi
and how sure
car
they
tu tukar
are
jadi robot.
whether the nerve
Kita
is
punya
cut. If they're not sure, probably because of the tumor around it, can't find the nerve, I would identify the nerve intralaryngally by cutting the inferior part of the superior constrictor muscle over the thyroid cartilage and find the nerve over there which is pristine, wouldn't be touched by anyone, and follow the nerve inferiorly. So if the nerve is intact, I would be able to find the whole course of the nerve inferiorly. But if it is cut, then I would find it cut and proceed with non-selective reinnervation. It's always that cases where there's a high chance we need to do non-selective reinnervation. I always now I don't have to do so, but last time I have to oh Rahaiza, please keep the answers cervicalis for me. Nani, please keep the answers cervicalis for me. So we can use the answers cervicalis
Ada dua je.
to repair the nerve. To get the proximal part is very unlikely because there's tumor over there encasing the nerve. So the answer is I would proceed with non-selective laryngeal reinnervation, answer cervicalis to recurrent laryngeal nerve, and later on injection as I mentioned in the previous lecture.
Thank you, Prof. Marina. So what if in this situation there's different scenario in which right recurrent
Kita ada dua
nerve
fish,
is
dua
also
hamster.
compromised? So will that in any way affect the management of the recurrent nerve?
Dah habis. Alamak.
Okay, so if the opposite recurrent laryngeal nerve is involved, let's say it is totally transected, I would put my hands off, I wouldn't do anything. I wouldn't do reinnervation, I wouldn't do injection because there is chance that the patient may have stridor or stop, and I do not want to worsen the condition. But let's say the opposite side of the recurrent nerve, probably just one event, and it's not even 3A as Prof. Raizat mentioned, 100% vocal cord palsy. There's chance that this is just neuropraxia, and then the patient would gain the mobility of the vocal cord later on. I would just do non-selective reinnervation, but I wouldn't inject. Just reinnervation. I wouldn't inject. So there is the question in the Q&A just now asking me whether would I consider doing selective reinnervation on table if both recurrent angina is transected. In ideal situation, yes, but it is difficult because of logistic reason. Doing selective reinnervation in good hands take about 8 hours because you need to find phrenic nerve, you need to find great auricular nerve, you need to find both sides of ansa cervicalis, both sides of recurrent laryngeal nerve. So if possibly in good hands you can do that surgery in 3 hours, or not, you can do at the same technique. If you can't do that, don't do anything. Wake the patient up slowly. When the only extubate when the patient in control of the respiratory muscles, and see whether the patient has stridor or not. If no stridor, no need tracheostomy, just observe.
Thank you, Prof. Marina. So I think I've managed to cover all the major aspects of this case through this scenario. So Prof. Nani, would you like to add anything, Prof? did I miss anything?
Mawada, may I say something about the issue when you have compromise on the opposite side and the protocol on
Yes,
the
Prof.
opposite side? I think whoever using the nerve monitor, you must really understand how to interpret the results. It's not just simply amplitude is there or not. I think I did highlight there are situations that there will be a very good recovery, but there are situations that the amplitude is still there, but actually the patient will go into palsy. So it's very important because if you wrongly make the decision and the other side is already palsy, and then you also did the laryngoplasty on the palsy side, then you will get the bilateral palsy, you'll be in trouble. So I think very important if you want to learn the nerve monitor, learn it properly. And I say the best is still to get the continuous nerve monitoring because you can reduce all these possibilities. You cannot say 100%. Even with a good hand, you still can get nerve injury.
There are two questions, Prof, on continuous nerve monitoring. One is the from Senia, low V1, the first reading. Can we dah jawab yang video compression? Yang the second one, the Rushdie, from Rushdie, the Taiwan method.
Tak ada, belum jawab.
Taiwan method usually bagi kita the bigger better EMG response. Should we lower the stimulus to less than 1 milliampere?
Okay, at the moment, there is no guidelines on this. The guidelines still follow the standard international guidelines where you should look at the 50% drop in the amplitude. It's just that you have to adjust the measurement on the machine. Because the NIM3 machine, the maximum is only 2,500. So if you get the reading amplitude of 3,000 or 4,000, it will go beyond the sky. So that's what you have to remember. So if you get dropped with 50% of 4,000, that's 2,000. And the machine may not be able to pick it up. So yes, you have to play around with the values now.
Ni macam apa?
Thank you, Faraiza. And Prof. Nani, do you have any other things to add?
Tak ada, Mawada? No.
Okay. So I think that would wrap up our session for this evening. I'm sorry it's been a long day for all the panelists. I would like to thank Professor Baki, Professor Dr. Irfan Muhammad, Prof. Rohaiza Muhammad, as well as Dr. Liu for taking off their time off their busy schedule today and entertain all the questions from the participants. So with that, I would like to end the webinar for today. Just a reminder, we will be sending e-certificates and we will be doing the registrations for you for the MSc certificate points. So thank you everyone and have a nice evening. The panelists nak ambil gambar.
Jadi nak patahkan.
So the CPD point will be submitted by the academy later, right? There's a question from
Yes.
Kita tak boleh ambil gambar dengan participant kan nanti?
Yeah, we cannot because they are.
Kami tak boleh ambil.
Jadi sambung boleh.
Yeah,
Cannot Prof, because they are now in video.
Okay. But I think we have to take a picture with our speakers and.
At least kita tak perlu pakai mask.
Siapa nak ambil? Screenshot. Saya ambil. Bye. Okay. Lagi nak apa? Okay. Saya tak dapat macam ni. Okay. Thank you everyone. Thank you for Raiza, for Irfan, Dr. Liu, Dr. Nadia, Nani, Mawada, Marina. Okay. Everyone. Bye-bye.
Bye.